With this, we move on to our last presentation, which is Pearls and Pitfalls in Interpretation of OCT and Diagnosis of Glaucoma by Dr. Sanjoy Daulat Thakur. Spelling it there.
Good morning, everyone. My previous speaker, Dr. Jasleen, was talking about the confounding factors in OCT. So that is basically my topic, pearls and pitfalls in interpretation of OCT. We have to remember that basically there are 4 different manufacturers of the spectral domain OCT, and we study 3 different parameters for glaucoma. The most important thing to remember is that each machine has different scan patterns, software segmentation algorithms, and display outputs. So we cannot compare the data of one machine with another. First of all, we must check the patient's name and age to identify, and then all data is compared with age match normative database and color coded accordingly. Next, we must check the signal strength. Each manufacturer has minimal acceptable quality. For Cirrus it is more than 6, for Spectral it is more than 15. So we should remember that lower signal strengths will give lower RNFL thickness, which improves with rescanning, and a drop of lubricant will not only improve the signal strength but also the RNFL values. And it has been reported that there is a 9% increase in average RNFL thickness after cataract surgery. We should also know the color codes properly, just not red and green but white and gray also. The values more than 95% of the range is labeled as white, and the values that are not compared with the normative data are color coded gray. So we usually only stick to red, green and yellow. So in our over enthusiasm for embracing OCT in the diagnosis of early glaucoma, as they say, we sometimes just follow the red and green and diagnose based on OCT only. So each technology has its own limitations. Like these blood vessels may cause shadowing and lower RNFL values. In the past, we used to have this motion artifacts characterized by horizontal displacement of images, but with newer machines, this is no more a problem. Sometimes a floater comes in the path of the calculation circle and we get lower RNFL values. So if we ask the patient to blink and the floater moves away from the calculation circle, then the values are back to normal. So all these artifacts can be broadly divided into 3 groups: patient dependent like media opacities, operator dependent like signal strength, and device dependent because of the limitations of the normative database. So here is a picture from Heidelberg printout which shows a lot of red areas, and if we see the fundus, we see that this RNFL thinning is due to toxoplasmosis and not due to glaucoma. So it has to be clinically correlated. So this is a retinal disease and not a glaucoma. Another picture from Cirrus printout showing lot of RNFL thinning, and when we see the disc, it is myopia. So in myopia, the superotemporal and the inferotemporal bundles converge temporally. So the height of the hump is normal, but it is displaced laterally. So we get red areas in the normal expected places. So this is due to myopia and not due to glaucoma. This is another picture showing lot of red areas in the RNFL table, but if we see carefully, we see that the disc has not been centered properly. And once the disc is centered properly, all the values come back to in the green range. So this is a centration error by the operator. Another picture from Heidelberg showing a lot of red areas and TSNIT graph dipping into the red sector. And if we see carefully, the RNFL segmentation has not been placed centrally, and once this is placed centrally, all the values turn to green. So this is another centration error by the operator. Another picture showing lot of red areas in the sectoral analysis and even in the TSNIT graph even dipping to 0, which is not possible because there are some glial cells and blood vessels, so the RNFL values cannot go to 0. But this can occur in tilted disc, posterior staphyloma, and peripapillary atrophy. So this is a segmentation error by the device. Another problem with the devices is a limited number of database. For example, in Cirrus, only 284 healthy individuals are recruited in the normative database, which are in the age range of 18 to 84 years and refractive error range of -12 to 8 diopters. So many results may be flagged abnormal statistically in patients who are not represented in the database. Thus, they do not represent the real disease. And we should be alert about these facts and not overtreat this red disease. The vice versa can also occur. In this printout, you can see only left eye is having glaucoma and the right eye is not glaucomatous. But if we see carefully the disc, the myelinated nerve fibers have increased the RNFL values in the right eye, thus masking glaucoma. So this is an example of green disease where we may miss glaucoma because the OCT does not pick it up. One another limitation of the OCT machines is the floor effect. As I was saying, the RNFL values cannot go below 40 microns because of the presence of the glial tissue in the blood vessels. So in advanced glaucoma, we have to rely on automated perimetry rather than OCT. To summarize, OCT alone should not be used to make the diagnosis. An abnormality in the OCT requires clinical relation, and it is not man versus machine, but man plus machine. Thank you, Chairman Scientific Committee, Dr. Partha Vishwas and his team for allowing me to present this.
Thank you, Dr. Sanjoy. It's a wonderful presentation, and we all know red-green disease.